I'm going to discuss some of the important high yielding topics today. So these high yielding topics are definitely going to help you. It will give an insight. This session will definitely give you an insight. Overall, what are the topics you have to concentrate so that you can save your time and perform well in your examination. First, let us move to the first question here. A 3-year-old child has extensive vesicles on the lip, tongue, oral mucous membrane. After 2 to 4 days, vesicles ruptured, followed by pseudomembrane formation and some dermal lesions seen. What will be the diagnosis? See here the question says extensive vesicles. And vesicles, where are the vesicles? Vesicles are present on the lip and the oral mucosa. And these vesicles have ruptured. And they have formed a pseudomembrane there. And the history also gives the patient has some dermal lesions. What will be the diagnosis? So whenever we come across these terminologies here, that vesicles are there and they have ruptured, vesicles have ruptured, and they are present where? These ruptured vesicles are all present in oral mucous membrane and dermal lesions are there. So obviously it is a type of erythema multiforme. EM stands for erythema multiforme. Now in the option, if you see, herpetic stomatitis is there, erythema multiforme is there, ANAG is there, Stevens-Johnson syndrome is there. All of us know erythema multiforme is of two types. One is a major type, one is minor type. Minor type means which affects only skin. It will affect only skin. Whereas major type is which affects the oral cavity. Now major type examples are Stevens-Johnson syndrome and TEN. All of us know toxic epidermal necrolysis. Here they have specifically mentioned that there are oral manifestations. So obviously it is a major type, and in major type they have given option Stevens-Johnson syndrome. So Stevens-Johnson syndrome is the correct answer here. Stevens-Johnson syndrome is the correct answer here. Okay, so here Stevens-Johnson syndrome, we can see basically it will have the oral manifestations, extensive crusts, vesicles will be ruptured, and there will be bleeding and crustaceans. Blood will be oozing out continuously. You can see in this image, the patient, you can see carefully, there will be oozing of the blood from the lips particularly. Remember, the most common site is lips. Stevens-Johnson syndrome, the most common site being lips. Okay, now one second. Yeah, so so that is the most common confusion among the students. How to identify, how to differentiate whether it is erythema multiforme you have to answer, or whether you have to answer the Stevens-Johnson syndrome. So that all depends upon the whether oral manifestations are there or not. If oral manifestations are there, then obviously it is going to be the Stevens-Johnson syndrome. So moving on to the second question here. Is SJS occurring in children? Yes, it can occur. SJS, Stevens-Johnson syndrome, can occur in children. There is no hard and fast rule that erythema multiforme can occur in elderly. It can occur in any age group. Children can also get affected. That's one of the doubt. Now moving on to the next question here. So here I want you to differentiate whether it is any, that's the most common confusion among the students, whether to answer erythema multiforme or Stevens-Johnson syndrome. Specifically, as Stevens-Johnson syndrome is given in the option, that will be the correct answer. If oral manifestations are not there, then you have to go with erythema multiforme. Okay, moving on to the next question. A 22-year-old female patient complains of elevation of the eyelid on the mandibular movement to the contralateral side. What is the most probable diagnosis? You can see the two images here. In the first image, here there is a ptosis. What is ptosis? The elevation of the eyelid. Okay, and along with that, you can see the mandibular movement is in the opposite side. So when the mandible moves to the opposite side, eyelid, there is a muscle here called as levator palpebralis. So this muscle, because of that, there will be the elevation of the eyelid leading to ptosis. What is the most probable diagnosis? The most probable diagnosis for this is a classical syndrome called as Marcus-Gunn jaw winking syndrome. So whenever you get this question, relation between mandible and eyelid, think of this syndrome, Marcus-Gunn jaw winking syndrome. Okay, remember it is always contralateral side. Contralateral side. Okay. This contralateral side, why exactly it occurs? It exactly occurs because of the aberrant communication between the oculomotor nerve and mandibular division of trigeminal nerve. We know that there is a trigeminal nerve has got three divisions: ophthalmic, maxillary, and mandibular. The mandibular division and the oculomotor nerve, there will be aberrant communication. Because of this aberrant communication, whenever the mandible moves, because of the activation of this nerve, the oculomotor nerve starts its function. Thereby, there will be ptosis or elevation of the eyelid. So this is called as Marcus-Gunn jaw winking syndrome. There is one more important point. It is also a type of congenital oculofacial synkinesis. Sometimes they can ask you as an option this only. They might not ask you the Marcus-Gunn jaw winking syndrome. They can ask you oculofacial synkinesis. Syn means what? Syn means synergistic. Kinesis, movement. Oculofacial, face and oculo eyelids. Because of the mandible movement, the eyelid movement takes place simultaneously. This is called as congenital oculofacial synkinesis. So you can expect option like this also, rather than Marcus-Gunn jaw winking syndrome. Okay, I hope this is clear. Now, let us move on to the next question here. The next question is a histological image. A 12-year-old girl presents with a soft pedunculated mass. See, soft mass and pedunculated. See, read the question. I always insist the students to read the question carefully. You will get lot of clues. Pedunculated mass. That means it has got a stalk. Where? On the tongue. So there is a soft pedunculated mass on the tongue. Excisional biopsy was done, and this biopsy was stained with the HND, hematoxylin and eosin stain, and the image is given below. What is the probable diagnosis? See, what you can see here in this image, I'll just highlight for you people with a red color. There is something like this, something like this, something like this. You can note here, these are nothing but papillae. These are nothing but papillae. So we have papillae which are finger-like. You can see they are finger-like. So this papillae which are finger-like projections, histologically, histologically is characteristic of squamous papilloma. So squamous papilloma is one benign condition, benign tumor of the oral cavity which is caused by the virus HPV. Human papilloma virus, particularly 6 and 11. HPV 6, HPV 11 are the two types which commonly cause this squamous papilloma. Remember, squamous papilloma is a benign tumor. It is not related to anything malignancy. HPV 6 and 11 are the two most common organisms. And this squamous papilloma typically occurs on tongue. Tongue is the most common location. That is why in the option also they have given, in the description they have given tongue. So tongue, pedunculated or finger-like pedunculated mass, finger-like projections histologically or clinically also. Clinically also, when you see these patients, they will have white color lesion on the tongue, and those white lesions, they will have finger-like projections. That is nothing called as papillary projection. So we see papillary projections on the tongue, thereby the diagnosis would be squamous papilloma. Okay, so we can rule out Hex disease, oral cancer, or Cannon's disease. So how we can rule out Hex disease? Usually doesn't occur on the tongue. Oral cancer doesn't present as a pedunculated mass. It will present as an ulcer. Cannon's disease is white sponge nevus. Cannon's disease is white sponge nevus. Remember, this will also not occur on tongue specifically, and it will not have these finger-like projections, papillary projections. Okay, so that is the question that we are supposed to. So you have to look at the image soon for your information. In next in the next coming this week, you will get PDF on eMedico's app. On the eMedico's app, DAMS eMedico's app, you will get a PDF which will be a compilation of all the histological images. So I am expecting some of the, we have discussed during our classes, but I am expecting some important histological images, so which I will be uploading as a PDF. It will be uploaded on your eMedico's app. So I will inform you on the WhatsApp group as soon as it is uploaded. Please go through it. It is definitely going to be a last minute revision for the histological images for oral pathology. Definitely it is going to help you. Okay, so if images will come, definitely you'll answer. It's not that you'll lose any image based question. You're definitely going to answer it right. So stay tuned. So in next 3-4 days, probably next week, well before your exam, well before 1 week before your examination, so you will get the compilation. All images we have discussed, but you will get a compilation of that on the DAMS eMedico's app. So squamous papillomas are exophytic tan white lesions. Histologically, papillomas are composed of a proliferation of uniform squamous cells with the central fibrovascular core. There is nothing much to remember in this. So just the same what we have discussed. Moving on to the next question. A 38-year-old patient presents with pain and swelling in the maxillary anterior region. There is history of trauma 1 year ago. Please, there is a pain, there is a swelling in the maxillary anterior region, and patient gives a history of trauma 1 year ago. On percussion, there is tenderness. When you percuss the tooth, there is tenderness. Biopsy was done, and the biopsy shows the following histological image. You have to identify the marked structure. See carefully here. In this image, I am able to see a lining. I am able to see a connective tissue. I am able to see a cystic lumen. So definitely it is going to be a cyst. And in this cyst, if you see carefully here, we are going to see, I'm just zooming this. Lot of such structures. What are these structures? There are some structures like this, curvilinear structures. So all these curvilinear structures, these are called as nothing but Rushton bodies. These are nothing but your Rushton bodies. So Rushton bodies are one particular structures which are eosinophilic structures, pink structures, curvilinear structures, hairpin-like. It is textbook describes that hairpin-like. Typically, it is present within the epithelial lining. So location is important. You will never see Rushton bodies in the connective tissue. You will always see within the cystic epithelium. You will see always within the cystic epithelium. I'm very glad you people are answering the question. Very good. Rushton bodies are peculiar eosinophilic, linear, curved, hairpin-like or straight glassy structures within the lining, epithelial lining. This is very important. Rushton bodies is always seen in case of lining, epithelium. You don't see in the connective tissue. Most commonly, you will see it in radicular cyst. This is the most common cyst where you will see almost 10%. Frequency is 10%. That means if 100 cases of radicular cyst are there, 10 cases are going to definitely show this Rushton bodies. Next will be dentigerous cyst where 4 to 10%, and then odontogenic keratocyst which is 7%. Okay, so order here important is, don't remember there's nothing called as order here. Most common is radicular cyst. You can also see in OKC, you can also see in the dentigerous cyst. Average both are same, 7%. But most commonly radicular cyst, that is 10%. So these are nothing but your Rushton bodies. Now, there are many bodies histologically. How to identify? See, how to identify that these are Rushton bodies only. One clue already have told you, shape. Look at the shape. They are curved shape, hairpin-like, pink structures. Okay, but there are many structures in the which are pink color in the eosinophilic. There are something called as Russell bodies. All of us know there are Russell bodies. What are Russell bodies? Russell bodies are nothing but collection of immunoglobulins. They also appear pink in color. Now, how to identify that these are Russell bodies? These are not Rushton bodies. How to identify is, Russell bodies will always have homogeneous nature. They'll be pink means uniformly pink. They will be round shape. They will be pass positive. If you use per-iodic acid Schiff stain, Russell bodies will be positive, but Rushton bodies will not be. So Rushton bodies are not homogeneous. Rushton bodies are hairpin shaped. Rushton bodies are not pass positive, whereas the Russell bodies are homogeneous. Russell bodies are round in shape. Russell bodies are pass positive. So this is what you have to identify, or you have to remember how to differentiate between Rushton body and a Russell. Rushton body and a Russell. Moving on to the next question. Geometric glossitis is caused by. So what do you mean by geometric glossitis? Means there will be, geometric means something related to map. So there will be glossitis or depapillation in particular areas. So that is characteristically seen in herpes simplex infection. Okay, in herpes simplex infection, glossitis that is seen is known as geometric glossitis. Now, what exactly, do you see this in all patients? No. We see this geometric glossitis particularly in immunocompromised patients. HIV positive patient. For example, there is a HIV positive patient. If that patient develops herpes simplex, the patient might develop geometric glossitis, where typically on the dorsum surface of the tongue, there will be fissures, and those fissures will be painful, and they will have a branched pattern. So there will be central fissure like this, and there will be fissures like this on the tongue. So this is known as geometric glossitis. So branching is important here. Along with that, the patient will also have herpetic ulcers. So you might ask, sir, how do I differentiate this geometric glossitis from fissured tongue? Yes, you can get confused, but there will be associated herpetic ulcers. You have to identify those ulcers. Okay, and this is very important. Immunocompromised patients, fissured tongue, there's nothing much relation between fissured tongue and immunocompromised states. But geometric glossitis has got a strong relation with HIV positive patient or any immunocompromised case. So remember, it is very painful. Lingual fissures on the dorsal surface of the tongue with branched pattern. And it is not caused by HSV2, HSV1, obviously, because HSV1 is the one which causes oral lesions. Herpes simplex virus 1 is the one which causes oral lesions. Hence HSV1 causes geometric glossitis. Moving on to the next question. Mode of inheritance in ectodermal dysplasia is, we know there is a skin disorder called as ectodermal dysplasia. What is the most common mode of inheritance in these patients? Ectodermal dysplasia patients are typically X-linked recessive. All of us know males have got XY and females are XX. What happens in ectodermal dysplasia is one X chromosome will always be defective, whereas in females one X chromosome is normal. Males have only one X chromosome and that X chromosome is already deceased. I mean to say it is mutated. Diseased means it is mutated. So ectodermal dysplasia typically affects males, whereas females are carriers. Females are carriers. Why females are carriers? Females are carriers because females have one normal X chromosome, whereas males, they have one normal X, males have got only one X chromosome and one Y chromosome. Whatever X chromosome is there, that is already mutated. So obviously males are affected, and this is known as lionization or Lyon's hypothesis. I think I've discussed this in a slide here. Yes, lionization or Lyon's hypothesis is nothing but this only, what we have discussed. And this is very typically asked. Why it is so classically asked in the examination? Because it is X-linked recessive. Males will be affected, females are carriers. Somewhat same like your hemophilia. Hemophilia is also X-linked recessive. Males are affected, females are carrier. In hemophilia also we will see lionization or Lyon's hypothesis. Now what is the gene responsible for this? Ectodysplasin A. You have to remember this gene. Ectodysplasin A. Sometimes they won't ask you the mode of inheritance. They can ask you this gene also. So please remember this name of the gene. Ectodysplasin. It is ectodermal dysplasia. They have taken ecto, they have taken dysplasia. Just A, instead of A, they have added dysplasin. Okay, dysplasin A, ectodysplasin A. That is the gene that is mutated in case of ectodermal dysplasia. Now, moving on to the next question here. 22-year-old. Any doubts till now? Whatever we have discussed. Any doubts? Please let me know. A 22-year-old patient presents to the dental clinic with painful oral ulcers. Histopathology revealed ballooning degeneration of epithelial cells and inclusion bodies. What is the probable diagnosis? See here. First of all, painful oral ulcers. First itself, the clue that is giving is painful oral ulcers are there. There is ballooning degeneration of epithelial cells and inclusion bodies. What is the probable diagnosis? Ballooning degeneration of epithelial cells is again a characteristic feature of herpes. Now, what is ballooning degeneration? Ballooning degeneration is something called as cytopathic effect. We know in herpes there is an inclusion body called as Lipschutz bodies. Lipschutz bodies. Now, in context of herpes simplex, ballooning refers to cytopathic effect. What do you mean by cytopathic effect? Because of the virus herpes simplex, the epithelial cells will change. They will become round. They will become swollen. They will lose their cohesion. So cells become something like this, round cells. Round cells. Okay. So these round cells are nothing but your ballooning cells, and there that loss of intracellular or intercellular cohesion is called as acantholysis. So we are going to see acantholysis here, where there will be loss of intercellular. I'm sorry, it's inter, it's not intra. Inter. So there is a cytopathic effect or ballooning degeneration with the presence of Lipschutz bodies, and there is nothing but acantholysis. In HSV, ballooning degeneration is often accompanied by other histological features such as multinucleated giant cells. What are those giant cells? They are nothing but your Zank cells. Zank cells. You can see Zank cells, right? So Zank cells which you see in pemphigus, you can also see that in herpes. So multinucleated giant cells can be seen called as Zank cells, and there will be acantholysis there where there is a loss of cell cohesion. Loss of cell cohesion. Okay, moving on to the next question here. Multiple punched out radiolucency of skull is seen. Classical question, need not discuss anything here. It is a typical myeloma, multiple myeloma. Typical multiple myeloma, punched out radiolucencies. Okay, myeloma or multiple myeloma is a characteristic case. There is nothing to discuss here. This image you have to remember. Bilateral mandibular expansile lesion is a feature of mandible bilateral. Again, this is straightforward cherubism. Cherubism. Cherubism, we know that typically affects in children. There will be bilateral mandibular involvement. Remember, there will be mandibular involvement. And now cherubism has been described. Cherubism has now been described as a type of fibrous dysplasia. So cherubism typically affects mandible and maxilla. There will be a gene that is mutated here, that is SH3BP2 gene. And the first radiographic sign of cherubism is seen in mandibular angle. Remember, earliest a radiologist can diagnose a cherubism by looking at the radiolucency at the angle of the mandible. Okay, so that is a clue that this is a case of cherubism. This is a case of cherubism. So cherubism is characteristically caused by the gene that is SH3BP2 gene. Moving on to the next question. How is widened and elongated coronal pulp chamber represented in Dentin dysplasia? We know that in Dentin dysplasia, there are two types, type 1, type 2. Type 1 is radicular dentin dysplasia, type 2 is coronal dentin dysplasia. In coronal dentin dysplasia, the pulp will be enlarged and that pulp is called as thistle tube pulp or flame shaped pulp. Remember, dentin dysplasia type 2, that too particularly permanent teeth, not a deciduous teeth. So dentin dysplasia type 2, permanent teeth, sorry, the pulp will be enlarged, that is described as thistle tube or flame shaped pulp. I'll show you a radiograph, that very classical radiograph. Please look at this. We'll see the written part later. What they say, this is the thistle tube. And how is the pulp in the root canal? You can look at this. This is so thin. Look at this. I'll just erase this for you so that you can appreciate. Look at the pulp in the root canal. It is thread-like. So thistle tube pulp chamber with a thread-like root canal is characteristic of dentin dysplasia type 2, that 2 permanent teeth. Dentin dysplasia type 2, that 2 permanent teeth. Okay, so this image again is a very classical image. Please try to remember this. Which of the following lesion is characterized by involvement of eyes, laryngeal mucosa, vaginal mucosa, oral cavity, and subepithelial bulla? Again, this is a favorite topic in INICET or AIMS previously. So there is a skin lesion which will affect mucosa, and there is a subepithelial bulla. All of us know pemphigus has got intraepithelial bulla. Pemphigoid has got subepithelial bulla. The pemphigoid which affects mucosa is a cicatricial. Bullous will affect only skin. Bullous will affect only skin. It's not pemphigus, please. It is pemphigoid. That to which type? Cicatricial. What is cicatricial? Mucous membrane pemphigoid, which will affect mucosa. Pemphigus will show intraepithelial bulla. Pemphigoid will show subepithelial bulla. And you should see the history, whether they are giving that whether mucosa is involved or not. If mucosa is involved, then definitely it is cicatricial pemphigoid. Then it is cicatricial pemphigoid. Okay, so cicatricial pemphigoid is also known as mucous membrane pemphigoid. I'll just show you an image of this. Look at this. This is a classical subepithelial bulla. This is a basal cells. These are the basal cells. Now below the basal cells, we are going to see this cleft or the space. That is nothing but your subepithelial bulla or nothing but your the pemphigoid. This is the direct immunofluorescence finding, DIF. Direct immunofluorescence finding of the pemphigoid. That's not much important. You will not concentrate on this. They won't ask you this. So just remember that pemphigoid, that too cicatricial, is the one which affects the mucosa. Moving on to the next question. Premature loss of primary teeth, enlarged pulp chambers, and skeletal malformation can be seen in. Typically, there is one metabolic disorder called as hypophosphatasia, where the patient will have loss of primary teeth. Usually, we see mandibular incisors. They will exfoliate around 6 to 7 years, but in these patients, very young age only, there will be exfoliation. So hypophosphatasia typically affect mandibular incisors. It will typically affect mandibular incisors. Okay, there will be enlarged pulp chamber, that is shell teeth is seen in case of hypophosphatasia, and there will be skeletal malformation, bone abnormality in case of hypophosphatasia. So hypophosphatasia typically affects the exfoliation of the primary teeth, particularly mandibular incisors. Remember why mandibular teeth only are affected, not posterior teeth, because mandibular teeth, they will have short root, they will have a single root, they are more susceptible to lateral forces. Because roots are single, roots are small, very short, they will erupt earlier, hence they are more susceptible to lateral forces, and hence there is a high chances that they are exfoliated more than the posterior. That is a hypothesis that has been given why particularly in hypophosphatasia mandibular incisors, primary mandibular incisors are exfoliated. Which of the following is not a histopathological feature of CGCG? What is CGCG? Central giant cell granuloma. Central giant cell granuloma. What are we going to see? We are going to see few to many multinucleated giant cells. Yes, we are going to see. And those giant cells, they will originate from monocyte precursors. Yes, monocytes only give rise to giant cells. First and second both are correct. Eosinophils are present in the connective tissue stroma. No. CGCG will not show any eosinophils. Eosinophils, presence of eosinophils means you should remember two things. You should remember two things, eosinophils. One is Langerhans cell histiocytosis. LCH will show presence of eosinophils in the connective tissue, and Cherubism also will show eosinophils in the connective tissue. So this is the correct answer. This is not a feature of CGC. Erythrocyte extravasation and hemosiderin deposition can be seen. That means RBCs come out, hemosiderin pigment is seen. Yes, in CGCG, you will see all those things. I'll show you an image of this. Look at this. These are all multinucleated giant cells. Okay, you can see so many multinucleated giant cells, and this is what is your hemosiderin pigment. This red color that you are going to see is your hemosiderin pigment. So multinucleated giant cells, extravasant RBCs, hemosiderin pigment are all features of this CGCG. Presence of eosinophils is not a feature of CGCG. Okay, moving on to the next question. All of the following are true about white sponge nevus except white sponge nevus typically is autosomal dominant. Yes, it is true. It is bilateral buccal mucosa, symmetrical white corrugated plaques. Yes. They are asymptomatic. Yes. It is pre-malignant lesion. No, it's wrong. White sponge nevus is totally benign. Totally benign. It cannot convert into malignancy. White sponge nevus cannot become cancer. It is not pre-malignant. So white sponge nevus typically is harmless condition. Textbook describes it as harmless condition with no potential for malignant transformation. So white sponge nevus cannot become or cannot convert into cancer. Okay, moving on to the next question here. Which of the following histologically ameloblastoma resembles? Ameloblastoma, we have to remember is it is basically invasive but does not show metastasis. It will not show metastasis. So ameloblastoma has got same clinical behavior and histologically as that of basal cell carcinoma. So correct answer here is basal cell carcinoma. So which of the following is not true? Premalignant lesion is not true. This is not a premalignant lesion. Multinucleated giant cells are seen in all. Aneurysmal bone cyst, yes. ABC, yes. Hyperparathyroidism, yes. Solitary bone cyst. You don't see in case of solitary bone cyst or traumatic bone cyst, you will not see these giant cells. So multinucleated giant cells are not a feature of SBC, solitary bone cyst. Moving on to the last question for today's discussion. Which of the following is a tumor marker for SFT, solitary fibrous tumor? There is a tumor called as SFT. It is a fibroblastic, and this tumor is classically STAT6 positive. STAT6 positive. Now what exactly is STAT6? STAT6 is basically a highly sensitive specific marker for SFT. It's a IHC marker. IHC is immunohistochemistry. So it is basically a fibroblastic neoplasm, solitary fibrous tumor. There are many fibroblastic. How do I say this is SFT only? I'll say fibrosarcoma. I will say malignant fibrocystiocytoma. How do I prove that this is SFT only? Use this marker, STAT6. If it is STAT6 positive, it is SFT. It is SFT. Okay, so that is some of the important topics, MCQs, which I wanted to discuss here. So all the best, dear students, for your upcoming examination. We are going to have this on the eMedicos app, that PDF. Go through that PDF, all the images. Any doubts, you're always free to contact me on the WhatsApp group or in the same YouTube video. You can put it in the comment box. I'll answer any of your doubts. Okay, so that images will be very useful. So that is, don't worry, there is nothing new in this. We have already discussed that. So, but I'm going to compile it. It will be very handy for you people, and definitely I'm expecting some questions from that. I had some doubts with the question how you can tag me by the name Pawan Kulkarni, Dr. Pawan Kulkarni. There's a doubt that in the group, how do Dr. Pawan Kulkarni, you can tag me. Any doubts? I'll answer your questions. I hope this session was useful for you, and definitely we are here to solve your doubts, to help you out, and all the best. And any doubts, you can ask me. Definitely, if not today, you can post it. I'll definitely solve your doubt. Okay, thank you so much.